I would like to ask Mr. Andoniganakis about, it's okay about the restoration. I would like to ask some things about, a question about the prevention of the instability. And I'm referring to young athletes between 14 to 17 to 18 that we meet, and they have some slight instability and a big elasticity to the shoulder. I would like to have a few words about the prevention in order not to to go to the restoration afterwards.
Well, we have to keep in mind always that we are dealing with the function of the shoulder. And in order the shoulder to be stabilized, it's a skill, it's a motor skill, like bicycling, for example. It's quite the same. So what we want is to improve the skill with physiotherapy, with the right kind of exercising, the right kind of physical exercising adventure. When we are thinking of operations, we are thinking of changing the anatomy in order to make it easier. That's what we have to keep in mind. So when we have a patient, a lax patient who is dislocating his shoulder without trauma, the first thing we have to do is to try to change the way the shoulder functions. And if this is acceptable, and if we can succeed this, no operation is needed, no change to the anatomy. If this fails, then we have to try to see how we can change the anatomy in order to make function possible.
It was clear, thank you.
Another question? Okay. I have a question to the speakers. They prefer the lateral jet procedure. As we saw, the lateral jet procedure has neurological complications, contrary to free implantation of a graft. How you can avoid it? Okay, in France is a country where the selection criteria of the surgeon is too much anatomy. In no other country there is so much lessons on anatomy like in France. What do you mean? What do you mean? If someone outside of France begins to perform a lateral jet, either open or arthroscopic, what he has to take care? At first, Mike, or some of the other speakers who are for lateral jet.
So I don't do any arthroscopic lateral jet, but with the open lateral jet, I think that if you follow the steps, then the possibility to have a neurological injury, because this is what we're talking about, especially for the musculocutaneous nerve, it's really very, very low. So you just have, in arthroscopic lateral jet, it's completely different. Sometimes you cannot control the bleeding. After 2 hours, maybe you're not so well concentrated. But for open surgery, it's a 35 to 40 minutes operation. So if you stay close to the coracoid, not going too medial, then the possibility to do a complication, it's really very, very low.
Yep.
Actually, our experience is different. We published our series of open lattaches in 2008, and we had 2 serious nerve complications of axillary nerve with the open series, and we had unacceptable rate of early osteoarthritis in these cases. So our results are actually far better now with the apparently far better with arthroscopic lattache. I think it's a technical question. My concern is not the nerve injury during the operation. That can be solved. That is a surgical thing, and if you are accurate and you visualize the nerve, you can preserve it. My major concern with lattache is that it's an extra anatomic procedure. You alters the anatomy and the function of the shoulder, and a revision is a very dangerous thing. you actually then need to go medial, isolate the plexus, dissect out all the nerves to protect them before you start tumbling around. So my major concern with arthroscopy, with l'attaché, is that it's an extra anatomic procedure, and I wish we could move forward and find something better. But for the moment being, I didn't find anything that I could trust better than the l'attaché in these cases where you have no soft tissue to work with, and there is combined soft and bony injury.
Thank you. Dr. Azar and Dr. Toussaint.
For me, also a nerve problem is not so much a problem because as we make the split from posterior to anterior, and then as I will show on this afternoon, we especially for me because I'm a young arthroscopic l'attaché maker, so I'm not as quick as Mr. Boileau, and the shoulder with me is a little bit bigger at the end of the operation. But when you go in the front part of the shoulder to make the split, the first thing you have to check is the rotator interval. From there, you see all the stitches you have prepared for the bankart. Then you go low to the bicipital groove. You find the three sisters, and when you follow them, you will find the two brothers. You put just a retractor. Usually, the splitter is just below the subscap in this point. And after putting the retractor, you just have to push a little bit and open the split. So normally, you don't have problem with the nerve as you control it with your eye. You don't have normally. I have seen Mr. Boileau talking many times that we can't fix the bone block before seeing the nerves. So you have to check for them. If you check for them, you can't injure them. After that, sometimes more than a real nerve injury, you have a nerve palsy, and it's due to the fact that the tangent condyle is a little bit too tight. So we usually make a release after positioning the graft. We don't put the maximum pressure at the beginning, the maximum tension at the beginning. We just position it in front of a glenoid rim. And after, with the switching stick, we just release the medial part of the tangent condyle, conjunct tendon, just to have a little bit more space. And we do it with the arm in the neutral position, not to block also the nerve when we are in the overhang position after that.
Thank you very much.
Thank you. I mean, it's very different for open l'attaché and arthroscopic l'attaché, because in open l'attaché you move the arm external, you move the scapula externally, and you move the nerve medially, and you have more space to work. Arthroscopically, you cannot move the scapula as well, and you have some big relationship between the nerve and conjoint tendon. And if you stay lateral to the conjoint tendon, you are safe and you cannot damage the nerve. But you need to, and Tom said very well, you need to go step by step, control. If you have any doubt, you need to control the nerve to be sure you don't damage it. Because the second enemy of the surgeon is the anatomical variation of nerve, and sometimes you need to check the nerve to be sure you don't damage it during the procedure. But certainly, if you are inside the joint as Ettore, you reduce the nerve injury as well.
And just to conclude, maybe, because as a young surgeon performing the arthroscopic l'attaché, I think the most important thing to say is that arthroscopic l'attaché is just a manner to do a l'attaché, but you can. I'm not sure that arthroscopic is better or worse than the open one. It just depends of what you are used to do and what you are confident in your surgery. maybe younger surgeon start arthroscopy from the beginning, so there will be more. It will be more easy for them. It will be easier for them to perform arthroscopic lateral surgery. But I think it doesn't matter if you do open or arthroscopic. The fact is that in the end, your patient should be stable, and that's all.
Okay, any other questions? Yes?
We've heard from all the previous eminent shoulder surgeons speakers about different ways of fixing the graft, the bone block, or different ways of performing the same operations. And as we gathered from another speaker as well, there were quite a few modifications done by the same surgeon along the evolution of the same technique. I wanted to ask them, performing a lateral Z procedure, do they have to fix the capsule in front of the graft always? Some others do, some others do not. Does it relate to arthritis in the future if they don't do capsule repair, labral repair on the top of the graft or not? What is their experience about that? Thank you.
So, Tom, do you want to answer? It's about the repairing of the capsule. Yeah.
Actually, the answer to that is I don't know. I think nobody knows. I think the main purpose of the capsular repair would be to increase the stability and the physiological function of the shoulder. But this is my opinion. I cannot support that by any science. I don't know why, but we had, as I mentioned in our open series, more osteoarthritis than we see in our now closed arthroscopic series. I cannot really say why. In the arthroscopic technique we are using, we do not fix the capsule. We just put the bone graft in position and fix the bone graft. And we don't close the split in the subscap, and we don't do anything with the soft tissues. So I just can't really give a good answer to that. I don't know if Mikael can.
I agree with Tom, but I close the subscap. I don't repair the capsule. I don't think that it makes really any difference.
So we have to go on because we are out of time. In the afternoon, we are going to have these techniques, video of these techniques, and you can ask also questions if you like about these procedures. Okay.